that is very much fascinating for me, that your scope is not limited to the patients that you are providing direct patient care. But if you improve patient experience, or if you improve or reduce hospital-acquired infections, or you improve the readmission rates, the impact is much broader. And you can really, make your communities healthy as well.
Hello, everyone, and thank you for listening to another episode of our podcast. Today, I'm speaking with Dr. Navneet Dang, Chief Medical Officer at Geisinger. Navneet has been practicing internal medicine for over 2 decades now and underpins his inpatient care and clinical practice with robust knowledge in business administration and medical management. He leads Geisinger with a focus on quality and performance improvement and has been spearheading transformational changes in every role he's had. Navneet, thank you for chatting with me today. I'm excited to dive deep into all of this. And just before we do that, could you take a few moments to tell us a bit about yourself?
First of all, thank you, Ohad, for having me today on your podcast. It's truly my pleasure to be here today. As you already mentioned, my name is Navneet Dang. I'm an internal medicine physician by training. I grew up in India, did my medical school there, and followed with the general surgery residency. I practiced general surgery for 2 to 3 years in India. Then I moved to Canada because I met my beautiful wife who was in Canada at that time. So kind of got the flavor of a single-payer health system in Canada, but then quickly decided to move to United States, did my internal medicine residency. And I practiced traditional internal medicine for initial 3 to 4 years, where I kind of took care of patients through the whole continuum of care in the hospital, in my office, and also followed them in the post-acute space. I have been with Geisinger for about 8 years now. I have been in various leadership positions. Most recently, I was the System Chief Quality Officer and System Chair of Inpatient Medicine, where I have been leading various initiatives around patient quality, safety, and patient experience. And for last 2.5 years, I have been in the role of Chief Medical Officer for Geisinger Community Medical Center in Scranton and oversee clinical operations in our Scranton market. I'm glad to be here.
Well, there's a lot to unpack there. Actually, I have to start, though, with a personal angle. I also met my wife in India and ultimately moved to Canada. I'm Israeli originally. I met my wife backpacking in India, and she dragged me kicking and screaming at first to Vancouver. But of course, I've grown to love it. And so sounds like we share a little bit of a similar destiny. We ended up in Canada for love. And so where are you from originally in India?
I'm mostly from North India.
North India. Okay.
Yeah.
I find healthcare in India to be so fascinating, right? Because there is large government and public involvement, but also very much kind of a private fee for service, especially in primary care, is my experience, right? So tell me a little bit maybe about the Indian health system. What is that like?
Indian health system, I would say that it's more private than public. So there are a lot of private healthcare entities, private practices, private hospitals. And when I grew up and when I practiced in India, the insurance theme was only available in, I would say, the bigger metro cities like Mumbai, Delhi, Bangalore, and some of the bigger cities. But now, over the last 10 years, obviously, I have been in US now for 18 years, but landscape of healthcare has changed a lot in India. While there are still a lot of private players owning private hospitals and private practices, but there are a lot of insurance options that people can choose from.
So without insurance, it's kind of a cash business, basically direct. Wow.
Yes.
Very interesting.
Yeah.
All right. And then, so started your medical career in India in this very unique, kind of more private-oriented setting. And then you moved to Canada, kind of our socialist version of North America. What was that like? And where did you start in Canada?
Originally, I came to Toronto because that's where my wife was living and studying. I mean, it's great to have that universal health system, but I quickly found that access is a big issue, and the wait times, whether it's the emergency room or access to specialty care or even primary care, it's long. And then I decided this is not the system that it's going to be possible for me to practice, because I was used to a totally different way of practicing.
Exactly.
And then decided to move to US.
Yeah, that's a real dichotomy, kind of a cash-based system versus really a substantially public-oriented system. And I agree, living here in Canada, and there's a lot to thank and to appreciate for the Canadian healthcare system. But like you said, also a lot of challenges around access. And it strikes me also that there's a bit of kind of internal tension in how healthcare is structured here, because on the one hand, it's a single payer system with the provinces being the payer. On the other hand, the physicians are paid in a fee-for-service model.
Yeah.
So there's some incongruence there, right? You're either single payer value-based care, or you're multi-payer fee-for-service, which is more close to what the US is. But here there's a little bit of a mix that sometimes creates tension, and to me doesn't always get the right outcomes as it relates to access. And so then you make the move, you move to the US system, and you start in, you ended up in Scranton, Pennsylvania, of all places?
I mean, I initially moved to Pittsburgh, and I did my internal medicine residency at Allegheny General Hospital in Pittsburgh. And then after I finished my residency, I joined a traditional internal medicine practice close to Chicago in Midwest. Mm-hmm. And I was there for about 4.5 years, and then really wanted to move back to Pennsylvania because I wanted to be close to the family in Canada. So we moved to Geisinger about 8 years back, and I have been in various leadership positions within Geisinger, and most recently as Chief Medical Officer, as I mentioned, for the last 2.5 years.
And tell me, so how is care at Geisinger structured? Is it predominantly fee-for-service or value-based?
I mean, first of all, a little bit about Geisinger. I don't know how much you know about Geisinger, but Geisinger is an integrated health services organization and is widely recognized for its innovative use of technology and the development of innovative care delivery models. So there is a wide array of health services, providers, and capabilities that Geisinger has. It really evolved from a very small rural hospital in Danville, which started about more than 100 years back. But now we have 9 acute care hospitals with multiple campuses with close to 2,200 beds. We have a Geisinger health plan, and we take care of about, I would say, 550,000 members as a part of our Geisinger health plan. We also have education arm, which is our Geisinger Commonwealth School of Medicine. And we have close to 580 students and a multi-specialty physician group with 3,000 employed physicians. And they are practicing across more than 200 clinic sites. And we also have training programs with close to 550 residents and multiple fellows in various residency and fellowship programs.
That's fascinating to see so much growth and such a progressive kind of integrated approach emerging from kind of a relatively rural or smaller area in Pennsylvania. I guess not unique. You see that in quite a few of the really top health systems in the US. Often their origins are actually in smaller places. But maybe a point to come back to is the fact that at Geisinger, you're, for a large percentage or a large portion of your covered lives of your patient base, you're both the provider and the payer. And maybe let's get a little deeper into that, because we kind of talked about the dichotomy between like a very privatized system like in India, a very public system like in Canada. Is the solution to have more of this integrated care where the payer and the provider are one, and therefore you have all the right incentives to ensure that you're delivering prevention and delivering care, because you also own the outcome and the cost of that patient. Talk to me about this integrated approach.
Yeah, so I would say that before I moved to Geisinger, I mostly worked more in a hospital-based practice where we did not have a payer arm, if you will. And the focus was always on, you have really more of a siloed approach where you are really kind of investing in the patient outcomes when they are in the hospital, or whether you are seeing them in the clinic. But as a part of integrated healthcare model, we are really able to take care of the patient through the whole continuum of care. And I would say that the focus is on overall outcomes, not just in your silo work stream, whether you are practicing in the hospital or whether you are practicing in the clinic side. Our focus is on making better health easier for our patients and communities. And that is our vision as a health system. I don't know if I made sense.
It does. And I'd love to come back to this point on outcomes, because as a healthcare technologist, we're often trying to figure out really how to best measure and quantify outcomes. But maybe just before we come back to that point, just to kind of round out your journey. So you started though in clinical practice, and it sounds like you're still a practicing clinician.
Yeah.
Why did you decide to cross over to the dark side, to hospital management, administration, leadership? That's a tough burden to bear.
Yeah, no, that's a great question. Let's put it this way. When I started my journey in India, I never thought that my goal was to become a physician, right? And I thought practicing medicine is such a noble profession. And specifically in rural India, there are so much challenges around access to high quality care. And that was my why to becoming a physician. And as I practiced, and I have been in practice for 15, 20 years now, one of the things that was intriguing for me, when you are practicing clinician, you are only able to impact the lives of the patients that you touch, right? That you are in direct patient care. So if you are practicing in an outpatient practice, you can only impact the lives of the panel of patients that you are directly responsible for, right? But once like you said, moving to the dark side, right? The administrative side.
Yeah.
One of the things I enjoy is optimizing the processes. And once you optimize one process, you can really change the outcomes for millions of patients or even the broader communities that you serve, right? So I think that is very much fascinating for me, that your scope is not limited to the patients that you are providing direct patient care. But if you improve patient experience, or if you improve or reduce hospital-acquired infections, or you improve the readmission rates, the impact is much broader. And you can really, make your communities healthy as well. So I think that is what's fascinating for me.
That is truly a noble calling. And just knowing a little bit about the inner workings of hospital and health systems, I realize how difficult of a job that is, right? Because you're steering a very, very large organization, and you're obviously extremely limited by the pace with which you can change things, because you're dealing in the day-to-day of a very challenging and complex operation that involves hundreds of thousands of people, and change management, and clinical and regulatory limitations and financial ones. So very much grateful actually to have people like you that are taking on that challenge, and also keeping in touch with their clinical practice while they're doing that. So again, in this discussion, we've come back to outcomes a few times, which kind of the idea is that it's not about the process or the service. The idea is about the outcome. To what degree do you feel today that at Geisinger, or maybe even broadly as healthcare systems, maybe starting with the US, do we really have a handle on how to measure outcomes? And are we measuring the right things?
Yeah, that's a great question. And that's a loaded question. We have a lot of programs that we really participate in as a part of Geisinger Health System. I can tell you that Geisinger is a very data-rich organization. And we have a lot of internal tools where we are able to track our performance. And one of the ways that we are able to quantify our patient outcomes is by using a tool which is called Vizient that really gives us an opportunity to not only just do internal benchmarking, but we are also able to benchmark ourselves against other like-sized health systems. We also participate in a lot of programs through CMS and Leapfrog, and there is a huge focus on measuring our outcomes and not just measuring them, but pick the signals where we have the most opportunity and focus on those data points to improve patient outcomes. So we participate in CMS programs and also the programs through Leapfrog, but also track our performance by using Vizient and some of the other internal benchmarking tools.
So it sounds like part of the solution to this is working with organizations that have a broader mandate that either see extremely broad spectrum of clinical use cases and outcomes like CMS as the centers of Medicaid services or Vizient as a GPO, I think the largest group purchasing organization in the US. So strong benchmarking data. I think something like 3,000 hospitals participate in Vizient. Okay, that's interesting perspective. So you're saying kind of the knowledge of this broader group is what helps you understand really how you're benchmarked and where you're going from that. What about the actual measurement? You said so a strong data orientation at Geisinger, so that's obviously important. But I'm not sure you answered the question of like, are we measuring the right things? You know, a lot is talked about hospital-acquired infection, ER throughput, length of stay. Are those really the important measures? And kind of how do we continue to evolve that to know that we're ultimately getting at the best outcome for the patient and also for the clinician, which I know has been kind of as the quadruple aim has become more front and center, the role of the clinician and their satisfaction and what they do has also been rising in importance.
We measure all the outcomes that you mentioned. So one of our strategic focus is, to improve our quality ratings to CMS 5-star, right? And if you look at 5 broader buckets of quality in CMS 5-star, they are around readmissions, mortality, patient experience, and also safety of care, which encompasses all the hospital-acquired infections and some of the other hard measures, which are part of safety of care, and also timeliness of care. So, and there are close to 52 measures that CMS measures that go into this CMS rating. And we focus heavily on all the measures or the 5 big buckets of quality. And if you continue to focus on these 5 big buckets of quality, which are readmission, mortality, patient experience, safety of care, and timeliness of care, you can be rest assured that you are providing high quality care for your patients.
That you're getting the right outcome. Maybe let's change gears for a moment. You know that I'm a technologist. I work in medical technologies. What role do you think technology has? And what role, maybe what's the call to action for us as the vendor community to help medical officers like yourselves really achieve that higher quality and that higher orientation for top outcomes?
I would say technology has a pivotal role to optimize patient outcomes. I will give you a few examples that how we have leveraged technology to improve patient outcomes. So one of the things that we have worked on is remote patient monitoring. I'm not sure if you're familiar with the remote patient monitoring tools that are available for our patients, where our patients can monitor their vital signs, they can monitor their weight, and they can also monitor their oxygen saturation once they are discharged from the hospital.
So this is like for post-acute patients, you're monitoring them after the fact using technology. It sounds like kind of in the broader metabolic syndrome conditions, right?
Yeah. And then you can also leverage technology to improve the care and the management of some of the chronic diseases.
Mm-hmm.
And we have seen that once we have leveraged this technology in terms of for appropriate patients who are high risk of readmission, we are able to move the needle on appropriate decrease in emergency room utilization and appropriate decrease in our inpatient utilization as well.
Got it. No, that makes a lot of sense. And actually, there's an angle on that in my kind of narrow neck of technology, which is ultrasound. I think I'm a big ultrasound geek, and I'm sure as an internal medicine physician, you know how to use ultrasound. Principally today, handheld ultrasound, or really all ultrasound, is approved for intended use by a licensed healthcare practitioner. And actually, we're working on a few angles to ultimately put it in the hands of patients. Now, of course, it has to be with the appropriate controls from a safety perspective, that the patients are not self-diagnosing, and probably AI is going to play a very important role in that. But maybe we can talk for a moment on do you see a role, for example, on ultrasound as a remote monitoring tool to play a role in helping to make these more informed decisions that you were saying, for example, whether the patient should be treated in ambulatory setting or go to emergency medicine. And today we have a pretty low-tech solution, right? You kind of look at fluid retention using an electronic scale. Could we not use like an ultrasound patch or ultrasound technology to measure interstitial lung fluid, and based on that decide, is this patient going towards a condition that has to be treated in the ER, or can we have maybe the physician in an outpatient setting change the titration or otherwise adjust the medications to avoid hospitalization?
I see that there is a huge scope of point of care ultrasound. Gone are the days when clinicians will just use their stethoscope to diagnose clinical situations. And I know that with the advent of point of care ultrasound, even in the ER, we are able to use a handheld device to see if patient has pneumonia or patient has congestive heart failure, which sometimes you're not able to totally diagnose on the basis of clinical exam with the help of stethoscope or just based on a plain chest x-ray. Even when we use point of care ultrasound, at 2 a.m. in the morning, you're seeing a patient in the emergency room who came in with lower extremity swelling, right? You don't know if patient has blood clot or this is just an infection from cellulitis, right? Mm-hmm. And you have to admit that patient and keep them until you get that ultrasound so that you can rule out DVT or a blood clot, right? Right now, all our teams are equipped with using a point of care ultrasound where you can diagnose these patients right on the spot. And once you have ruled out a DVT, you can discharge them on antibiotics right from the emergency room. So definitely the point of care ultrasound, there is a huge scope, and it has definitely changed the clinical practice for clinicians who are using it.
Do you think it could take the next step, though, to move from the hands of the clinician into the hands of the patient? Maybe not dissimilar to Holter monitors where you're monitoring, electrocardiograms remotely, or even Apple Watch monitoring atrial fibrillation, right? So it's more limited in scope than what a clinician can do when they're operating the machine, but maybe we could get there using AI as well to kind of statistically analyze so that we're not needing to put an image in front of the patient.
Yeah.
Rather, we're giving them kind of a yes, no answer on their condition, maybe with a number or a measure.
That seems like the most logical next step. I didn't think about it, but I'm glad that you and the team are thinking about some of those solutions. But definitely that's probably the logical next step, in my opinion.
And so maybe on that vein of, we talked about outcomes, and we talked about, moving care a little bit further down the chain, maybe ultimately to the hands of the patient. What about an interim step of, how do we get to focus more on prevention? Prevention is often the key to getting the outcome, but so much and so many of the measures that you noted also when you talked about those CMS measures were hospital-based measures.
Yeah.
Can we do more in an ambulatory setting or in a home setting to focus on prevention to avoid the situation where we do end up in the hospital and in the internal medicine bed, or even before that in the emergency room?
So there has been another great question. There has been a huge focus for us to move the care upstream, like you
Mhm.
said. How can we move the care upstream in the ambulatory setting, whether that is in primary care physician's office or whether that patient is being seen in a specialty care in cardiologist's office or a pulmonary physician's office, so that these patients are not coming to the emergency room for getting the care. But to do that, we need to make sure that our patients have access to ambulatory care. I think that has been a huge challenge across the country. So we really need to focus on how do we make sure that all our communities and our patients have access to primary care and specialty care so that they can get the care in that setting and they don't have to come to emergency room or get admitted in the hospital to get that care.
Is the limiting factor, Navneet, to that, to getting more ambulatory care in GP offices or in specialist offices, is it the financial model? Like, what's preventing us from enhancing the investments we're putting out in the ambulatory setting? Because presumably those investments have a very good ROI. We know that it's much more costly to treat patients in the hospital. So what's kind of limiting that access in this specialty office or primary care office environment?
So there are a lot of dynamics which are in play. So there is a huge physician shortage across the country in United States when it comes to primary care physicians and even our specialists. So we don't have enough of these physicians to provide adequate access, right? I think that's definitely one piece which is a limiting factor for providing appropriate access in the ambulatory setting. And we are leveraging advanced level providers or mid-level providers as a part of, optimizing access into these primary care and specialty care offices. And the medicine has evolved now to more as a team-based care rather than just physicians providing care to these patients.
Mm-hmm.
Under this team-based models, we have embedded pharmacists who are able to look at patients' medications and they are able to provide care. We have advanced practitioners who are able to provide care. So I would say, if I have to say what is the answer is team-based care, and also leverage technology and modalities like telehealth and AI to optimize access.
Yeah, that really good point around AI. If I bring it back for a moment to ultrasound, one of the missions that we've been on is to limit the hurdle rate for novice users to be able to use ultrasound. Historically, certain physicians at least, were trained at ultrasound, but much less so other allied health professionals, nurses, physician assistants, nurse practitioners. And in order to reduce the hurdle rate for novice users incorporating it into their scope of practice, we're trying to use AI, because we recognize that the new class of users, the newer generation of clinicians that are coming into the workforce, maybe can learn skills differently than what historically was taught, like in a residency program or in a med school. And a big part of that is like how my teenage children learn how to use technology. They pick it up, technology guides them on how to use it, using AI, using built-in tutorials, using videos and multimedia. Is that also one of the applications for AI that can help us to basically make it easier to use medical technology and enable these practitioners to expand their scope of practice to alleviate, again, that shortage of clinicians in the ambulatory setting?
Yeah, I think that's a great thought. And one of the struggles, like you pointed, our teenager children are much more tech savvy than at least I am. I don't know about you. And we see that dichotomy even in clinical practice. And a lot of our clinicians who have been in practice for, say, 30 years, and they are much more resistant to change and adopting new technology sometimes than some of our young clinicians who are right out of residency, and they had some exposure of these tools during their residency training. So we definitely see that, but your point is a good one, that we need to introduce some of these technological solutions, and even AI and point of care ultrasound right in medical school or right during residency training. I'm not sure if we are doing that enough at this point, but that might be one of the things we should be looking at.
I agree. Great. Well, we've already talked about your background, your journey from India to Canada to Scranton, Pennsylvania, about the balance and the difficulties of juggling a clinical practice and healthcare leadership, and then talked about where healthcare is today, with this big focus now at Geisinger and at other top-tier organizations, a big focus on outcomes, a big focus on remote patient monitoring, and on trying to move more of the care from the inpatient setting to the ambulatory setting. That gives us, I think, a really comprehensive view of where the world is today. Just as we start to wrap up our discussion, maybe as you look ahead, Navneet, where's the world going from a healthcare perspective? Kind of what does the future hold for us, maybe both in terms of challenges, but also in terms of opportunities to get these better outcomes and to continue to transform care?
As I pointed out earlier, we have to come up with innovative ways to provide the care closer to the communities, right? And the care does not necessarily need to be provided within the four walls of the hospital. We have to really make sure that we are focusing on the preventive aspect of care, which I don't think we have done that enough, right? And there are a lot of innovative programs that are being developed. Hospital at Home is just one of those, right? And where we are able to transition patients right from the emergency room and get them admitted in their home environment. And then the nursing and the physicians are able to take care of these patients in the comfort of their home environment, rather than getting them admitted to the hospital. Mm-hmm. And these novel and innovative programs are continuing to grow, in my opinion. There is a lot of work, and I will say that AI has made back office workflows much more streamlined than we ever had in the past. And we are also using AI to decrease the administrative burden on clinicians, that we need to continue to do that. Like some of the burden around patient messages and in-basket messages, and even around documentation. But we still have, I feel like we are still scratching the surface. We have a lot more that we can do with AI to augment even our clinical pathways. And there is much more scope in that space as well.
Excellent. Well, that is a lot to think about. It certainly has my juices flowing. That's pretty much all the time we have to cover today. But before we wrap up, Navneet, if our audience wants to keep up with you, where should they go? Where can they find out more information about you?
I'm on LinkedIn, and if you put my name in the search bar, they should be able to find me as Chief Medical Officer at Geisinger.
All right, so LinkedIn for our audience, look up Dr. Navneet Dang at Geisinger. Thank you so much for today. I know how precious your time is. And for all of our listeners, thank you for joining us for another episode of our podcast. That's a wrap. Bye-bye.